Good morning and welcome to this morning's discussion on the Psyfeld episode of The Revenge. That's right. All right. Any thoughts on where you would like to start? Anything that you thought was funny or interesting that caught your attention?
Can you hear me?
Yep.
I thought you mentioned as a joke, but there was a mention of suicide with, I think, Newman, even though we never saw the character in this episode, jumping off the building. And they also actually mentioned, factors in his life that could be contributing to the possible suicide, including not being in a relationship. I'm trying to remember another one, but I think that was briefly brought up too. So that's a quick point.
So let me hit the clinical pearls, which almost definitely will appear on a routine or standard shelf exam at the end of a psychiatry clerkship rotation. Number one, inquiring about suicidal thoughts, ideation, is part of a routine mental status assessment, period. Okay? Quite routinely, any clinician inquires about SI and HI. So suicidal ideation, homicidal ideation. Now, it feels a little difficult, and it should, but this is not the point in an evaluation to feel that you have to use comfortable terms that may or may not antagonize a person. There is zero in the medical literature to suggest or support that if you bring up issues pertaining to suicide, you will, quote unquote, plant the seed. That is just simply not true. What is true is if you bring up the issue and if you are not direct, you could miss a potentially suicidal patient. And that is something that a physician, that any clinician, simply cannot happen. So that is part of the routine assessment: suicidal ideation, SI, homicidal ideation, HI. Now, the unfortunate consequence is that the majority of people who have completed a suicide, who have died from suicide, have seen their provider within 30 days of that attempt and of that death. That is an unfortunate consequence. And in the majority of those cases, SI and HI, if seen by a psychiatrist, is actually part of the medical record documentation. So what everyone should appreciate this represents is that while inquiring about SI and HI are necessary, they are by no means sufficient. And that is why on a psychiatry shelf exam, if you ask about SI and HI but fail to ask about plan, imminence, and access, specifically access to firearms, you will fail your OSCE, period. Okay, that is a poison pill. That is a one and done. There is no discussion to be had. Miss any one of those components on an OSCE, and you fail. It's that simple. All right, so in addition to inquiring about suicidal and homicidal ideation, thoughts, the clinician must follow that line of questioning up, even if your patient, simulated or otherwise, answers no. So when that happens, there needs to be a reframing. Thank you for sharing. Now I want to ask 3 additional questions, which I routinely ask all of my patients. And that's when you actually have the go-ahead to ask about a plan, even though they just denied ideation. You could ask about imminence. If you were to be discharged from your clinical appointment today, would you go home, would you leave this office and attempt suicide? Imminence, very direct. And then finally, access to firearms. Now, this gets a little touchy because certainly firearms are the mechanism by way most completed suicides occur. So it's high yield. That isn't to suggest that there aren't other means, but that will not be a burden if you don't go through every single potential mean. If you go for the highest yield, that would be sufficient. Okay, so that's got to be part of your assessment. In clinical practice, however, that will not be enough. Okay, now in an OSCE where it's time limited and quite frankly it's an artificial environment, that will be sufficient to successfully pass your OSCE. However, in the real world, there's even more work to do. And at this point, you need to discuss with people like Newman what the independent risk factors are for suicide. Now, they're the same risk factors for violence in general. So that would include violence towards oneself. And this is where we review the acronym, the SAD Persons Scale. SAD Persons Scale, and this is actually published online, is an acronym that allows you to remember and therefore review the independent risk factors for suicide. Right? So, anybody want to tell me SAD, S-A-D, what those three risk factors are?
Sex, age, and depression.
Great. Okay. Now, just a little bit of a caveat with depression. It's depression plus other mental disorders too. Depression allows you to remember, but we would expand that to include other mental disorders, generally speaking. Okay. Anybody want to take a guess with regard to the PER in persons? Three additional risk factors.
Is it previous history of suicide attempt? E, is it alcohol or like drug use? And R is like if you're, is it like issues with your rational thinking?
Perfect. Okay. Yeah. E, of course, for those following at home, ethanol, other drug use. You nailed this. Okay. And then finally, SONS, the last part of our acronym. Anybody?
Separated or divorced. Is it an organized attempt in the past? N is, I think, no social support, and then the last S is if the patient states they have intent.
The last S is systemic illness.
Oh, I can't hear.
Oh, sorry. I think, can anybody hear me? Okay. Yeah, the final S is systemic illness, especially illnesses that are chronic and result in some lifestyle change, right? So systemic illness. That completes the assessment with regard to suicidality, and it is often referred to as the safety assessment. Now, upon completing the safety assessment on Newman, there are a couple of things that you'd want to discuss with your patient. Number one is their overall risk, and that has everything to do with the number of risk factors that they just endorsed. So 1 to 2 of those would be mild risk, 3 or 4 would be moderate risk, and 5 or more would be high risk. Of course, if the individual, and by the way, the O stands for organized plan. It doesn't have to be an attempt. It's an organized plan. If an individual selects that, if they endorse that, even in and of itself, that puts them at imminent risk, right? So that's the one that we really obviously pay very close attention to. Otherwise, it's a numbers game, right? 1 or 2, 2 to 3, 1 to 2, 3 or 4, and then 5 or greater, right? So mild or modest, intermediate, moderate, or finally high or severe risk. Okay. Now, there's a little bit more of the conversation you have to have with your patient in a clinical setting, and that is identifying those risk factors that your patient, Newman, just endorsed, and treatment plan for them. So if your individual patient endorsed 4 total, and you believe they are at intermediate risk, and 2 of those 4 are modifiable, they better appear in your treatment plan. All right, so that needs to be addressed. That is the safety assessment. It starts with the routine inquiring about suicidal and homicidal ideation that is simply part of your mental status exam. It evolves into talking and discussing an organized plan, imminence, as well as access to firearms, and then finally a comprehensive safety assessment That is the sad person scale. Any questions with regard to the character of Newman in this episode, the Revenge, or anything we discussed pertaining to suicide and the safety assessment?
Well, I know, throughout the episode, but also at the end of the episode, when Kramer was communicating with him and when we were hearing about the attempts, it almost sounded like he was kind of like looking for attention, but especially at the end when Kramer's yelling up to him and he says he's like, oh, I forget what he says, like, oh, do you want to go out to dinner or something? And he goes, oh, I can't, I have to go to a whatever. So I just thought that was it's, in terms of the show, I'm sure it's just comical, but if he was an actual patient, would that still be considered like a genuine suicidal ideation, or could it be something maybe like a histrionic behavior?
So that very question allows us to now discuss what in the medical literature is referred to non-suicidal self-harm. And that is individuals inflict harm on themselves with no clear intent to die. So non-suicidal self-harm is a clinical entity that, while not probably as severe or as high as a risk with regard to suicidality where there's a clear intent to die, is certainly significant problematic behavior nonetheless. So anytime there's any evidence to suggest that the individual, we'll call him Newman, does not have a clear intent to die, you'll hear this terminology. The one thing I think clinicians must do, however, is protect themselves and their patient from therefore thinking that what is going on is either less important somehow, less critical, or not real. It is still an acute situation that needs to be addressed. So that's non-suicidal self-harm. Now, if you do not believe your patient to be an imminent danger to themselves or other, non-suicidal self-harm, of course, would appear on the treatment plan. And as part of that, you do want to look for diagnoses or other reasons, other risk factors as to why the individual is demonstrating or manifesting non-suicidal self-harm. So that's where I'll leave it, because the differential there is incredibly varied. It would include the personality disorders, but certainly would not be limited to them. Right. Any other questions or observations? Any other characters you'd like to discuss this morning?
I just thought it was interesting, George's boss, and kind of how he talks about how he thinks he's like on top of the world, better than everyone else, and at the end towards the bar, he says that he's like the luckiest man, everything seems to fall in his lap, and he's just like, that kind of like, just, his overall thinking and thought process.
Yeah. So, what do you think about? We'll certainly discuss George's boss, and then I also want to talk about George as well. So, any other observations with regard to George's boss? He certainly comes off looking like a bully. And I wonder if he's using his current position to influence people in a way that would result in interpersonal conflict. I would very much be interested in the dynamic at that workplace. How about George, with regard to his reaction to his boss? How does he react?
George was acting really really impulsive, not thinking about the situation and being highly emotional at the same time. And I thought it was kind of interesting that he felt like he felt entitled to use the boss's bathroom, because he said like everyone else does it, but he also feels like, why should he stop using it just because he told him to? And that's just, the start of it. George has been doing stuff about, it's just a lot.
Anything else?
he was very apt to start using like drugs to hurt him, which I don't know. I mean, just watching the show so far, I felt that it was sort of out of character. I mean, he is very neurotic and impulsive, but like seeing him basically try to like physically harm someone, I was a little shocking.
What drugs does he use?
Rupees?
Yeah. Now again, for our medical students, these will appear on your shelf exam. You really have to get an understanding of these and look for different aspects, properties of these drugs to identify the most likely agent, most likely drug used. So generally speaking, any drug can be used. These are often referred to as club drugs. The other vocabulary you will hear, although I don't know if it will appear in a shelf exam, is the date rape drug, because these drugs not only cloud consciousness, but sometimes affect musculoskeletal function, respiratory drive. So date rape versus club drugs, we're speaking about the same thing here. My gut says on a shelf exam, club drugs might actually either be singled out, or you're going to get a clinical vignette where it's evident that that is what is being used, irrespective of what you would call it. Okay, so and any drug can do this. One of the most potent, one of the most overused of these drugs is alcohol. But this conversation, I want to focus on those drugs that are specifically identified as being put into people's drinks without their knowledge, so as to result in a change in mental status. Okay, so there are 3-4 major examples here. Anybody have a guess as to what these 3 or 4 drugs are?
I would guess high potency benzos or barbiturates, stuff like that. That could be very sedative.
Yep. So what's an example of a benzodiazepine that does this?
I don't know if alprazolam or what's a high enough dose.
Rohypnol is the one that comes up on exams a lot. Right? Rohypnol is the one that comes up on exams a lot. Now, what's the property of Rohypnol with regard to the drug, the club scene, and therefore what might be presented in a clinical vignette that will allow you to pick this drug called Rohypnol above the others? Anyone?
They all act through GABA, GABAergic. I don't know if we have more.
The one thing I want you to look out for in real life when you're at a club, on your shelf exam, is that Rohypnol. This is the benzodiazepine. Is often referred to, street name the roofie, and is often or does often color your drink blue. All right, so in these cases, if the drink looks blue and the individual has a reaction to it, generally speaking, it's probably Rohypnol that has been dosed. In this case, the terminology dosed means that the drug has been put in the drink, irrespective to the individual or consumer's knowledge. Okay, so being dosed with Rohypnol will lead to an acute mental status change, difficulty with musculoskeletal function, decreased respirations. It is a date rape drug, it is a club drug, and it can and often will turn the drink blue. Be very suspicious if you are purchased blue drinks. Rohypnol is one of these drugs. There's a couple of others that show up on exams. What are they? GHB, gamma hydroxybutyrate, GHB. Now GHB, unlike Rohypnol, actually has an intended effect, meaning that it has FDA approval for what?
Narcolepsy?
Great, narcolepsy. Very good. Okay. It also it very frequently addresses the excessive daytime sleepiness in narcolepsy. right? That's GHB. What is the property of GHB that the intended victim may actually pick up on, therefore, which may actually appear in a clinical vignette and a shelf exam? It is a salty taste. Okay, GHB is a salty taste. Okay. Unfortunately, except for the taste of GHB, and except for Rohypnol being blue, these drugs are often colorless, odorless, and tasteless. And the other one I want to just briefly discuss, we do think about this more in, I think, from a different context, the drug of abuse, even a drug with an FDA approval, but it's also a club drug, and that is ketamine. Ketamine is a dissociative anesthetic. It does have use both in humans for treatment-resistant depression as well as animals. It's still a veterinary anesthetic. But its dissociative properties are also the intended effects with regard to its abuse potential, and that includes being dosed. Ketamine. The other two drugs that are often part of this conversation, just to kind of build this out to 5 total, are salvia, which is a plant, from which a tincture can be made. The tincture, however, is bitter, so it is not tasteless. However, it's unclear, pardon the pun, as to whether it's truly odorless, so and colorless. So you have to be careful. And the final drug is one that was often referred to as the Mickey Finn, and that's chloral hydrate. There is no FDA approval for chloral hydrate. There is no FDA approval for salvia either. And what all of these have in common is they have a rather rapid onset of action within 60 minutes, relatively short duration. They impair respiratory drive. They impair sensorium. They can certainly impair musculoskeletal function. And in the case of ketamine, even dissociative effects. Salvia, more of a hallucinogen. All right. So those are the 5 club drugs. I think, I don't know if it's clear, again, pardon the pun, which drug George actually doses his boss with. Is it actually referred to as a roofie? Again, roofie versus Mickey Finn. Definite names attached, linked to 2 individual drugs when these drugs were commonly used, but now I think those street names are interchangeable. I'm not so sure. And you're never going to see that in the shelf exam. You're never going to have to pair the street slang to the actual drug. But Mickey Finn, chloral hydrate, and the roofie is Rohypnol, which is the benzodiazepine. Any questions about these club drugs? Again, remember, any drug can impair reaction time. Any drug can increase and or impair impulsivity. But these really stand out or separated from drugs like cannabis and alcohol, etc., because they have additional qualities that put them in a separate category, even though they're having different mechanisms of action. Again, ketamine and salvia are from the hallucinogen class. Rohypnol is a benzodiazepine. So, despite that, they are usually clumped together as club drugs. Have about 5 minutes left. Any other topics you want to discuss with regard to yesterday's episode, the episode you watched, The Revenge? One thing before we leave. I mentioned this before. It is definitely worth mentioning again because I did refer to hallucinogens. There are 3 subcategories of hallucinogens. One subcategory is called the psychedelics. An example of a psychedelic would be salvia. Another example would be LSD. The second subcategory are the dissociatives. An example of a dissociative is ketamine. Another example would be PCP. There is a third subcategory, the deliriants. Deliriants include anticholinergic agents as well as antihistaminic agents. Often medications that have the anticholinergic and or histaminic side effect. Benadryl is a common example. Benztropine, which is cogentin, another example. So, psychedelics, dissociatives, deliriants. Okay, we'll end it there. I will see the red team in about 30 minutes, and we'll see everybody else back at 12:30 for our Night's Watch discussion. Thank you.